So good morning. It's 6:30. It's maybe time to start. So welcome everyone to this monthly webinar on anesthesia for any critical care for lung transplantation. Today it's the last session of the year, and we are very happy how the collaboration has grown over this year. We started only 2 centers in August last year in August, and today we are nearly 60 to 70 centers. Difficult to count because not everyone can connect every day. The hours are difficult, and we know, but we're represented in 30 nations and in 6 continents. So that's fantastic. I just want to insist that after the presentation, we still can chat about the topics, and we keep the discussion in the ISLT Connect forum. We post the take-home message, and please feel free to post your thoughts, your questions. Everyone is able to answer. You don't need to be member of the ISHLT to be part of ISHLT Connect. Anyway, we also send the take-home message on X and LinkedIn, and I know I've been very long for publishing the website. It's under construction. It's almost there. I hope we'll have all the content online available, the videos and the take-home messages, and some more pedagogical material. So now it's time to introduce Archer Martin, that you all know. He will present the ISLT consensus on intraoperative ECMO for lung transplantation. Welcome, Archer.
Thanks, Julian, and thanks everyone for connecting this morning or afternoon or evening, wherever you are. As Julian said, today we're going to be talking about the highlights from the recent consensus from the ISHLT, specifically regarding the intraoperative ECLS in lung transplantation. Now, Julian and I do have some disclosures. Our financial disclosures are not related to this paper, but both of us were members of this consensus, and both of us are authors of this paper. This paper was really a massive undertaking. It's taken about 2.5 years for us to get to this point. We were approached by the ISHLT Standard and Guidelines Committee, and we have a total of 28 authors. Now, we're going to be talking about one paper today, but this is actually 3 manuscripts across JHLT, talking about preoperative, intraoperative, and postoperative use of ECLS in lung transplant. Of the 28 authors, we hail from 9 countries and 10 different physician and non-physician specialties. Across these 3 papers, there are 111 statements that met consensus, at least 75% of a vote through a structured Delphi of 2 rounds. There were 39 within the intraoperative proper, and as you can imagine, we're not really going to be spending time going through each 39 today. In fact, when the ISHLT posted this on social media, they had their top takeaways. There were 8 of them. This is just for the intraoperative consensus. Once again, if we went through each one of these as well, we really wouldn't be able to get through it for this entire time. You can see the website here listed below. So keeping with the standards of our global educational network, I'm going to be going over 3 teaching points as it relates to the intraoperative consensus. The first is that anesthesiologists and intensivists, those of us who have connected to this call, have a comprehensive perioperative role in lung transplantation. Second, the utilization of ECLS in lung transplantation requires an organ systems-based approach that's structured in its management, and it needs to be tailored to the end-stage lung disease of the individual recipient coming in for care. Finally, consensus statements such as this, they form the framework for answers, and they're not the final word. So it's important as we go through some of these statements and some of these principles that we keep in mind the various levels of evidence, the classes of recommendation, and ultimately, it'll show us a pathway where to go in the future. In terms of our role as anesthesiologists and intensivists, the ISHLT logo, which you can see here, has quite a few physician and non-physician specialties, everyone working together as a coordinated team towards figuring out the best answers for our patients who suffer from end-stage heart and lung disease. This is a picture of Julian and I having a dinner with colleagues at ISHLT. And in this picture, we actually have colleagues who are pharmacists, psychologists, respiratory physicians. Julian is an intensivist. We're both anesthesiologists. And so we can all come together to take care of these patients. And it's important that we do so in a structured fashion. But focusing on our role, the first statement that we're going to look at is this one from section 1.1. During this talk, you're going to hear me talk about the various sections and their titles. In this statement, we said increased recipient, donor, and surgical complexity within the practice of lung transplant necessitates multidisciplinary perioperative management, including surgical, anesthesia, and intensive care management. Now, when we look at each of these statements, there's actually a lot wrapped into them. And each of these statements also have a lot of discussion preceding them within the paper to sort of give our proofs for this. I think one of the key things to focus on here is that the practice of lung transplantation is becoming more and more complex. We're having less than ideal recipients, recipients who are getting older, who are sicker, who have more comorbidities. We're also having a less than ideal donor pool. We're having older donors, donors with other comorbidities. And the surgeons are becoming more complex. We do redo lung transplants, patients who have history of previous surgical interventions on their chest, and also just the use of ECLS increases complexity. So while this is not news to anyone here on this call, it is important to reiterate that we have a very, very important role. And it's not just in the operating room, and it's not just in the post-operative area. It starts with pre-surgical planning. We need to be able to have relationships with our multidisciplinary teams and strategies where we can communicate, and there's a facile way for us to handle problems well before they arise. The next statement we're going to look at is also part of the pre-surgical planning. An MDT discussion at the time of listing can be helpful to balance risk to benefit for proceeding to transplant with or without ECLS based on recipient comorbidities, such as etiology of end-stage lung disease, comorbidities, and ongoing clinical status. So when we look at this, not only do we have the foundation of that relationship, and one thing that you'll notice about these papers, each of them can be read individually for the phase, the pre, the intra, or the post. They can all be read from start to finish, start of the pre to the end of the post, and all of the principles are woven together. But one of the things that we do is that we build upon the principles throughout the case and really throughout the entire papers. So we start with the relationships, we start with our role. When we look at the actual planning sessions themselves, and we have to balance the risk to benefit, one of the key things here is that there oftentimes, and we'll talk about the levels of the data later, are not really high quality data to drive our practice. Therefore, it's important that we have nuanced discussions where we look at risk versus benefit for individualized patients. The next teaching point is that criteria for utilization of ECLS as intraoperative support versus no ECLS support include center expertise, recipient characteristics, and intraoperative team selection. This also shows the importance of our role, and one of the reasons why is that you can see that ECLS in lung transplant requires center expertise. It's not just a surgeon or an anesthetist, it's not just a respiratory physician who brings expertise to the table. You can have ECLS in lung transplant, and there are many benefits for that. But if you don't have a center team-based expertise, it's not going to work. So it's very, very important that our role is part of a team. So let's say that some of us on this call look at ECLS. It's something that we want to use in our centers. When we do bring these principles back to our center, we need to make sure that we do so in a multidisciplinary team fashion. Pre-induction initiation of ECLS should be considered in patients with severe cardiopulmonary failure, resulting in a high risk of hemodynamic collapse with the induction of anesthesia. Now, this also talks about our role because pre-induction initiation of ECLS in patients with the most severe end-stage heart and lung disease really depends upon the role of the anesthesiologist in the operating room. It's our job to be able to determine whether or not the patient is going to survive the induction of anesthesia. When we induce anesthesia, as we know, we have a massive effect on the 5 independent components of cardiac output, and we change the patient's physiology when we go from a normal state of breathing to positive pressure ventilation. It's important that we have a firm understanding of the principles that guide us during the induction of anesthesia and whether or not these patients need ECLS prior to that. Criteria for unplanned ECLS. The right ventricular function and PA pressures, evaluated using TEE and Swan-Ganz, should be assessed after PA clamping, unclamping, and reperfusion of the lungs. This also points to our role as anesthesiologists. As time goes on during the case, we need to have constant assessment of a diverse set of monitors. This means that we need to be facile in their placement, in their interpretation, and looking at them in time epochs related to the surgery. We need to make sure that we're paying attention to the field. And I know that these things sound very simple and very straightforward, but we're really using the consensus statement to build a case for the various aspects that will guide the multidisciplinary team to determine whether or not we use ECLS in the case. In this case, for unplanned ECLS, that call needs to be made by us in conjunction with the surgical team. So teaching point number 1 focused on our role as anesthesiologists and intensivists. Our role within ECLS and lung transplant is not just in the operating room, it's not just post-operatively, but it starts at the pre-surgical planning. But what about teaching point number 2? It's important that we have a complex management that's structured in a simple way. We need to have an organ systems-based approach, and we need to have it tailored to the patient's end-stage lung disease. This will help us in our guiding of a choice of ECLS, and as we look at some of the various organ-based systems, whether it's hematological, respiratory, or cardiovascular, it's important to keep that in mind. Having an understanding of the patient's end-stage lung disease is important as well. This is one of my favorite pictures because it's actually related to pulmonary hypertension, and it shows all of the groups of pulmonary hypertension within one slide. You can see group 1 PAH, you can see group 2 PH secondary to left-sided heart disease, group 3 PH, and so on. But it's important that we have a sophisticated understanding of what the end-stage lung disease that our patient is bringing to the table so that we can tailor their care to that ESLD. So when we look at the choice of ECLS in the literature, over the years, there's been a debate between ECMO and cardiopulmonary bypass. This consensus statement came out pretty strong and said that VA ECMO is the preferred choice for intraoperative support in standard lung transplants as compared to cardiopulmonary bypass. Now, when we look at this statement, there are a couple of words. So for instance, standard lung transplantation. When we talk about standard, what does standard mean? Well, it is a patient that doesn't have a concomitant cardiac procedure, for instance. So if your patient's coming in for a double lung transplant, but they need a cabbage, or they may need a valve associated with it as well, that's not going to be done on ECMO. You might do it on ECMO and then convert to cardiopulmonary bypass using a hybrid circuit per se. But it's important that each of these statements have nuance within them to provide flexibility to the teams. But generally speaking, VA ECMO should be the preferred choice. And when we look at choice of ECLS, section 1.2, intraoperative VA ECMO is not just preferred over cardiopulmonary bypass, it's also preferred over VV ECMO for cardiopulmonary support, regardless of the etiology of recipient end-stage lung disease. So as we look at VA versus VV ECMO, it's really outside the purview of this talk to get too deep into some of these individual statements. All that is to say, the group felt very strong that if you're going to use ECMO, you should use VA ECMO over VV. What about hematological? Section 2.4 actually had the highest level of evidence. This level of evidence stems from the excellent work done from our colleagues at the Prague Lung Transplant Program, who we've heard earlier in this year talking about some of their coagulation strategies. A transfusion algorithm should be used to decrease transfusion during lung transplantation. And when we look at the discussion behind that, which is extensive, one of the key phrases is that we recommend an algorithm created by a multidisciplinary team that incorporates point-of-care monitoring. It's important that we have a very sophisticated way to measure the coagulation strategy in the operating room, because that'll take us to the next level, where we can use low-dose heparin protocols. This statement notes, it is reasonable to consider a low-dose heparin protocol for VA ECMO during transplantation if adequate flows can be maintained. Once again, adequate flows need to be maintained. Low-dose heparin can have many benefits in this setting, but if you don't have a very nice, sophisticated anticoagulation strategy, you're never going to get there. So all of these statements build upon each other. What about the respiratory considerations? Anesthetic management of patients undergoing lung transplant with ECLS should be tailored to cardiopulmonary comorbidities of the underlying etiology of end-stage lung disease. Many of these principles that we talk about, once again, they seem extremely familiar to us, but we felt as a consensus group, it was very important to really provide this as a complete guide to colleagues who were either starting an ECLS program, who found themselves in issues, and needed to refer to some of these principles that built upon each other. Regardless of ECLS approach, the lowest possible FiO2 should be used upon reinflation and reperfusion of donor graft to minimize PGD. Now, this is backed up by some pretty rigorous data, particularly for the transplant world. It came from the lung transplant outcomes group. It's important to use an FiO2 of 40% or lower. I would say that if you're using ECMO, you might be able to provide yourself a situation where you can actually use air, use a lower FiO2 than 40%, but it needs to be at least 40% or lower when you're taking care of these patients. In double lung transplant, VA ECMO needs to be adjusted during the implantation of the second lung. A low but pulsatile flow in the PA is necessary to avoid no-flow phases through the first implanted graft. Now, you may wonder why this is under the respiratory part. After all, it's the ECLS flow and coagulation management section. Well, the reason why is when we put in these new lungs, if we treat ECMO like cardiopulmonary bypass and don't look at pulsatility and don't pay too much attention, as we might do sometimes with cardiopulmonary bypass versus ECMO, we're really not going to gain those benefits. In fact, it'd be quite harmful for the patient. After all, ECMO is cardiopulmonary support, whereas cardiopulmonary bypass is bypass. So it's important when we implant those new lungs that we have a slow but gentle pulsatile flow to allow for the controlled reperfusion of those lungs. Otherwise, the patients will be having warm ischemia during that time. So this is a key statement within this section as it relates to the lungs. What about cardiovascular? Constant assessment of diverse monitors, including echocardiography, urine output, and end-tidal CO2, is required to direct volume management during VA ECMO. This is really important because as we're examining VA ECMO in lung transplantation, if we use echo, for instance, which is one of our key monitors, and we'll talk about that, it's not going to be as accurate as we would think because we are diverting cardiac output away from the native circulation. So we need to have echo used in the appropriate context. We've had a lecture on that earlier this year within this network. And we also need to look at overall systemic perfusion. We need to look at things like urine output. We need to look at cerebral oximetry. And we also need to look at end-tidal CO2, which shows us the transpulmonary flow between the right and the left side. This is built upon furthermore in another statement where we say, in the setting of constant ECMO flow, volume resuscitation should be directed toward maintaining pulsatility in the systemic and PA waveforms during intraoperative ECLS for lung transplantation. Once again, as we look at volume resuscitation as a principle within ECLS, oftentimes we think back to the literature that has come out talking about the importance of having a restrictive lung strategy in lung transplant. And that's true in an off-ECLS model. However, an ECLS model, as many papers have noted, requires a more aggressive resuscitation. Sometimes it can be challenging to get out of the mindset that we need to keep them restricted, and oftentimes we may end up with no pulsatility in our PA or systemic waveforms. It's important to realize that the volume that we give to resuscitate the patient on VA ECMO is not necessarily all being exposed to the new lungs, and that we are diverting the cardiac output away, but we need to maintain enough of a resuscitation to ensure pulsatility and to ensure that the ECMO is flowing appropriately. As we look at monitoring, this is actually the first class 1 recommendation in the literature that TE should be used. Now, it's not that this is the first time someone says TE should be used. Many papers have described that, but no one's ever given it a class 1 recommendation. And our group said that we should consider TE a standard monitor in all lung transplants. Performing a comprehensive TE exam is recommended. Once again, we need to do this within the appropriate context and understanding of the impact of ECLS on the cardiovascular system. So what about our teaching point number 3? Teaching point number 1 talked about the importance of our role, not just in the operating room or the post-op area, but in the pre-planning area as well. And that's really a theme throughout all the papers that all members of the team have a role from pre all the way to post. The second one talked about the importance of structuring our management within an organ systems-based approach, also tailored to the ECLS of the patient. But what about teaching point number 3? Teaching point number 3 is that the consensus forms a framework. It's not the final word. And why do I say that? After spending 2.5 years on this consensus, I believe that there's over 600 citations through the 3 papers, and there were thousands of papers that were gathered and read by members of the team. We looked at the whole host of levels of evidence to make our recommendations. You can see those classes here. When we look at the lowest level of evidence, C2, which is expert opinion, out of our 39 intraoperative statements, 15 of those were based on C2. That doesn't mean that those are bad statements. That means that those statements were brought forward by a 28-member Delphi panel, discussed, debated through 2 rounds, and that we believe that these are the best recommendations. But 15 out of 39 were expert opinion only. Of those with low-level observational or retrospective trials, C1, 10 of the 39 statements form that. When we look at prospective or registry data, 13 out of 39, that's B2, and B1, which represents RCTs, was only 1. What this says is that we have an opportunity to make things better. And one of the ways that we talked about this in the consensus panel is we had a section that was looking forward to the future. One of the statements says, larger multi-center studies need to be performed to determine whether all or only specific patient populations benefit from elective ECMO. This is just one of the many unanswered questions that we have. And I think it's important for us to realize that if we're going to answer these questions, if all of us on this call spent the next few decades of our career trying to answer these questions in a high quality fashion, at the end of the decades, we'd have many answers, but we still wouldn't even have scratched the surface. So this is a huge academic opportunity. These questions are going to be answered not by individuals, not even by individual centers, but by passionate individuals consisting of teams across multiple centers across the entire globe, people who are here on this call today. And in the interim, as we're working on this academic opportunity, I think it's important that we focus daily on a process optimization. We do so from a quality perspective, from an outcome perspective, and that we share our process optimization over time. That's why it's so important for us to gather together every month and to gather online and to be discussing these ideas openly in free source. And it's very, very important as well that each one of us has humility. As we approach these patients, they're very complex, they're very sick. Oftentimes, it's the very worst day of their lives. And we don't have all the answers, and that's okay.
Thank you.
So it's very, very important that we use humility as we approach these patients. I will say that there are some efforts to answer some of these questions. If you look down here at the bottom of the screen, there are 2 PubMed IDs. These are of 2 RCTs that are ongoing for the use of ECMO in lung transplantation. And there's also a registered trial as well, which you can also see the number of. I encourage you to look these up, to look at the design, to ask questions about them, and look forward to the results that come from them. So coming back to our teaching points, our role in our professional community as anesthesiologists and intensivists is comprehensive. It's not just the OR, it's not just the post-operative setting, it's the entire perioperative setting. It's important that we have built relationships with teams where we can have these discussions and engagements and we have a seat at the table. When we use ECLS in lung transplant, it requires us to have a very complex management, but we need to break it down to an organ system space approach so we can easily edit, communicate, and train others. And we need to tailor it to an end-stage lung disease of the recipient coming in. Finally, consensus statements such as this one are great work, they're hard work, and they produce good results, but they form the framework for answers. They allow us the ability to move together as a team to answer these things in an academic fashion, and they're not the final word. And with that, I'll be happy to take any questions and discuss a little bit with Julian with the time we have left. Thank you.
Thank you very much, Archer. Excellent presentation. So that this time was not a clinical case, but the presentation of a huge work you've done. You've conducted with many people, and I would like to let the people ask questions. Nevertheless, I would like just to give my part. I think in the big question, should we put always an ECMO or not always an ECMO? I think the RCTs will help us to understand, but the most important is we shouldn't force the situation. If we're facing a difficult case, difficult hemodynamic management, difficult ventilation, we shouldn't force protective ventilation. ECMO will help us and will be smoother, and probably the surgery will go much better if we implant an ECMO sooner than too late when we are not able to maintain hemodynamic and respiratory failure. So we still have 5 minutes for questions. So please feel free through the chat or taking the microphone.
Julian, while we're waiting for questions, I wanted to sort of pick your brain on this. So, we have this framework for questions, but so many of these questions rely upon one another. And for instance, the RCT that are being conducted, these are huge questions about whether or not an ECMO should be delivered to a patient. Um, when we're thinking about how best to design these trials or where to start with our framework, do you think it's better for us to start off with those bigger questions or maybe build the case through smaller questions, whether it's the best way to optimize hematological management or respiratory management?
Oh, well, I feel that all these questions are legitimate and we should ask them. It's true that asking complex questions as always ECMO or in some case ECMO, it's very challenging because we face too many different population and many very different. So is our population in the study homogeneous to answer a question? No, probably not. And that's made the challenge, but we still need the answer to the question. Well, actually, we have a question from Morgan Lewen in Foch. What's the place for simulation in teaching teamwork? Oh, yes. Well, maybe Archer, that's for you, or do you want me to answer?
Well, I mean, I'll only say, and I look forward to your answer. I'll say that it's extremely important. And I know that there's probably even some experts on this call who do this, but I think that's absolutely vital. I know that there's been a movement, at least in the United States, for graduate medical education to really focus on high fidelity simulation for some of these complex procedures before patients are even brought into the equation. And that's probably more of an idealized situation. Not everyone has the resources for that. But I think it's absolutely vital, not just for an introduction for lung transplant, but also for ongoing maintenance of skills and bringing new team members on board. What do you think, Julian?
No, yeah, totally. That was the dream of the beginning of our collaborations, building a transatlantic simulation program and work on that. Unfortunately, it's much more challenging than this session, so has been complicated. And nevertheless, in liver transplantation, I've seen a very nice paper where they implanted serious game that may help maybe to have something like simulation, but we definitely encourage people to build simulation program, but not for a whole case, but for a specific situation of the lung transplantation, induction of the anesthesia, pulmonary artery clamping, reperfusion, well, these different stages of the surgery that can be very challenging.
Well, I think, the Toronto group has had some excellent simulation programs that are online. The University of Florida had some very early ones on the internet as well. So I think these simulations obviously require an expertise in computer science, but also driven by principles and data. That's way outside of my area of expertise, but whether they're, as you discussed, we had collaborated on a simulator that could be ported worldwide, that was low cost online, or something that's high fidelity in person. I think it's important.
Oh, well, please read the consensus. There's much more that what Archer could say today because it's huge. It has been a huge work. Everything is debatable because the level of evidence is low, but still, it's the beginning to build better work. And it's a call also for such collaboration as today, and simulation is one of them. Studies and trials are one of them, and also visiting centers and traveling abroad to see how other people work, because sometimes it's open the mind and say, oh, I thought that my way of work was the best, but I'm observing that the others looks great too, and I can maybe implement some good ideas back home. Well, with that,
Absolutely.
yeah, someone has a question.
Oh no, I was going to say I absolutely agree with what you said, Julian. Thanks for sharing that, and I hope networks like this continue to grow and expand in the new year, and that we have continued center participation so we can all learn and share from each other on these complex topics.
So happy holidays. Next session is on January 16th, same hour. And I hope we'll have the website with all the content because everything is recorded and we'll put that in the website. So thank you very much to all and have a great day, great evening, great afternoon, whatever, all around the world. And thank you very much, Archer. Bye.